All right, it looks like we have members here. We'll go ahead and call the meeting to order. This is the Senate Standing Committee on Health and Welfare, meeting number 2. The date is Wednesday, January the 19th of 2022. Madam Clerk, please call the roll.
Senator Rocky Adams. Senator Byrd.
Present.
Senator Carroll. Senator Givens. Senator Harper Angel. Senator Howe.
Present in the room.
Senator Kerr. Senator Nemes.
Present in the room.
Senator Wise.
Present in the room.
Senator Meredith. Present. Chairman Alvarado.
Present. Right, we have a quorum and we're constituted to do business. Before we begin, I think Senator Howe has a quick introduction of a guest.
I do. Thank you, Mr. Chairman. Alex, I have Alex Grayson with me here today. She'll be joining you next year in a medical school somewhere. She's got a couple in her pocket and is still working through that process, but she's a policy nerd like a lot of other people in her family, and was coming along today just to kind of check things out before she heads back to college to finish up. So welcome, Alex.
I can't. Is she behind that? There. Oh, there you are, right there. Very good. I get the masks. I can always tell. Welcome. Very nice to have you here, and glad you're joining the ranks of physicians like Dr. Berg and myself. We welcome you, and we need more physicians. That's for sure. So congratulations on that, and look forward to talking a little bit later as well. All right, we've got a quick agenda here. We've got 4 bills for consideration. We're going to start first with the fourth item on our agenda here, which is Senate Concurrent Resolution 20. It's a concurrent resolution establishing the Cabinet for Health and Family Services Organizational Structure, Operations, and Administration Task Force. The sponsor is Senator Meredith. Senator Meredith, if you'd like to begin your testimony.
Thank you, Mr. Chair, and I am Steve Meredith. I'm a state senator for the 5th District, and certainly is an honor and pleasure to get to present before this committee, even though I serve as vice chair. But to have 3 of the 4 bills today, I truly am honored by that, because I know we have a lengthy agenda for our session coming forward, and I just feel honored to be able to present these today. Starting with Concurrent Resolution 20. The intent of this is to appoint a task force to look at the operations of our Cabinet for Health and Family Services. And this is not a criticism of anybody that's in leadership in those positions or the employees that are part of it, but we recognize it is a monumental, huge cabinet for Kentucky. And you can look at the bill, the very first page, it lists is composed of Department of Aging and Independent Living, Department of Behavioral Health, Developmental and Intellectual Abilities, Department of Community-Based Services, on and on and on. And it's just hard for a cabinet that's large to be responsive to the constituents and to the people that they serve. And on the second page of this resolution, you'll see the things that we're asking for. By appointing this task force, we're going to be looking at examining the structure and operations of the programs and policies. So hope to do really a ground level review of all this, and we certainly want the cabinet's participation in this, but hope to make a change in this that will make it much more flexible, more dynamic, and more responsive to our committees and our constituents, the people we serve. So that's the essence of this bill, Mr. Chair. And if there's any questions, I certainly would entertain them.
We have a motion and a second on the bill. Any questions? Seeing no questions, Madam Clerk, please call the roll.
Senator Rocky Adams. Aye. Senator Byrd.
Aye.
Senator Carroll. Aye. Senator Givens. Aye. Senator Harper Angel. Senator Howe.
Aye.
Senator Kerr. Senator Meredith.
Aye.
Senator Nemes.
Aye.
Senator Wise.
Aye.
Chairman Alvarado.
Aye. The matter passes favorably with a count of 9 yeses, 0 noes, and no passes. It'll be reported favorably to the Senate floor. Congratulations, Senator. And the next on the item on the agenda we're going to go to is Senate Bill 43, an act relating to legislative oversight of health welfare issues. Sponsor again is Senator Meredith. If you'd like to begin on that bill.
Thanks, sir, and I appreciate you honoring my request to change the priorities on these bill presentations. The reason I asked for that is the Senate Concurrent Resolution 20 kind of leads into Senate Bill 43. And if you go to the very last page of that bill, you see that we would look to repeal both our Medicaid oversight and child welfare oversight. Our intent is not to destroy these programs whatsoever. Our real intent is once we go through this task force and hopefully reorganization, we'll actually elevate those 2 committees possibly to a standing committee. And we all know how beneficial that can be, because presently those of us who serve on these committees Usually, particularly Medicaid oversight, we will hear testimony, and then we'll have to hear it again in health and welfare. And we developed kind of a funnel in legislation that we can't get enough bills through to take care of all the needs we have. And there's only so much that we can do when we're in session like we are today. You're going to hear 4 bills. And I'm sure we probably have 20, 30 that are off in the wings waiting for some type of action. So what this does is actually anticipate that we will elevate, again, the status of child welfare oversight and Medicaid oversight, possibly to standing committees. But to accomplish that, then certainly these reporting functions that are in this bill would disappear. That doesn't mean the information disappears, because it still goes to the Legislative Research Commission. And I'd also point out that this doesn't take effect until January of 2023. So they'll still function like we always have in the interim. That information will still be there. But again, in hopeful anticipation that we can change this structure, that's the purpose of this bill. It is, I think, very innocent. It is not intent to bring damage or harm to any of the functions that are currently within those committees.
Very good. Thank you. Any questions? Question from Senator Wise. No questions. All right. Very good. All right. Senator Carroll.
Thank you, Mr. Chairman. Senator Meredith, and we spoke about this, so to make sure that I understand, and I asked this question because I have a piece of legislation that is related that would require a report to be sent to the Child Welfare Oversight and Advisory Committee. So the legislation, the point is to merge these two into one and move forward in that capacity. Is that accurate?
That's correct, Senator, yes.
Okay. Thank you. Thank you, Mr. Chairman.
Very good. And I think that's important to clarify. I know a lot of members on that committee. There's a lot of pride in that committee, and the worry was that they were diminishing. And I think there's an intent to elevate those moving forward. So we have a motion from Senator Wise. We have a second. Second from Senator Adams. Any other discussion? That, Madam Clerk, please call the roll.
Senator Rocky Adams. Senator Berg.
Aye.
Senator Carroll. Senator Givens. Senator Harper Angel. Senator Howe.
Aye.
Senator Kerr. Senator Meredith.
Aye.
Senator Nemes. Senator Wise.
Aye.
Chairman Alvarado.
Aye. Okay, again, by a count of 9-0, yes, nine yeses, no, 0 noes, and 0 passes, the matter is expressed favorably to the Senate floor. Next item on the agenda is Senate Bill 45, an act relating to the Medicaid program. This is a bill that we've heard here before, I believe, Senator Meredith, and again, you are the sponsor, so I'll let you begin.
Yes, it is. It's the deja vu all over again, or as I mentioned to Senator West in his Education Committee bill the other day, that it's like Groundhog Day all over again. And I'm very appreciative of the limited amount of time we have to discuss these bills today, but I just want to reflect a little bit about what's happened to healthcare, particularly in rural Kentucky. And I'm going to go back to 2010 with the Affordable Care Act, which we affectionately refer to as Obamacare now. And the intent of that legislation was to provide universal coverage to all of our citizens, but it didn't pan out that way. But Kentucky specifically, now we have 1 in 3 of our citizens are on Medicaid through this program. And I just want to remind everyone, and most people here have a healthcare background, but how Medicaid pays. Presently, it only pays 75 to 80% of the cost of the service. Cost, not charges at all. And this creates a disproportionate financial burden on rural communities, because the intent is, why would any government program only pay 75 to 80% of the cost? Well, the expectation is we're going to pass that shortfall on to commercial pay patients to private pay patients. That's one of the reasons insurance premiums are as high as they are, quite literally. But in rural communities, we don't have that opportunity to shift that cost. So think about it. Adding more people to the Medicaid program increases that financial burden. It's a proverbial, joke about raising watermelons for $1 and trying to sell them for 50 cents. Getting you a bigger truck and taking the market doesn't help you any, and that's what we are. Plus, another intent of the Affordable Care Act was to reduce any no pay. Everybody would have coverage. That didn't happen either. And again, you folks know that my background is hospital, so I speak on behalf of all healthcare providers. But specific to the hospital industry, when I left the business in 2013, the average profit margin, return on investment, was about 2.5 cents on the dollar. Today, it's less than 0.5%. And what has happened? Well, again, as you add more people to Medicaid rolls, there's no one to shift that cost to. So we have to look in terms, can we increase the reimbursement to our providers? I think we're working to do that, but that's just one element of it. The other is the administrative burden of the program, and it's substantial. So when I came in 2017, I think the first year I presented this was 2018, was let's reduce the number of MCOs from, at that time, 5 to 3. I wanted 2 because the federal government only requires 2, but kind of compromise and address the issue of what happens if we lose one of the MCOs like we did back in when the program first started. You know, when Governor Steve Beshear introduced the MCOs to Medicaid, we had 6. 1 abruptly left, did create chaos throughout the Medicaid system, and so we've been operating with 5. That bill that I've presented this year has not advanced beyond the Senate, but during the last round of negotiations for these contracts, we did reduce it to 4, so I thought that was very encouraging. But then it was challenged by the insurance companies, and as you all know, Judge Shepard said, no, we're going to do 6 until we get this thing lined out. So instead of reducing the numbers, we've increased the numbers. Now, folks may think this is just increasing, you know, administrative headache. It goes far beyond that. You know, if you're a large system, particularly in an urban area, you can afford to have people who specialize in the coverage of each MCO because every MCO is different. And I know I've shared with you folks before that my youngest son is a primary care physician in my home county, and he talks about, you know, if you need an order for something like an MRI, you can't just order an MRI. You have to determine which MCO is covering it. Then he has to be on the phone with another physician and say this is justifiable. And you have to do that sort of like 6 times. It's akin to, you know, trying to do your income taxes and being mandated you have to do it 6 ways. And to add insult to injury, having your income taxes audited by 6 different companies months afterwards and them recouping the funds. I can't begin to emphasize the administrative burden it places not just on healthcare providers, but particularly those within our rural communities. It's crushing. Again, I hate to have share war stories with you, but when I left my hospital in 2013, small rural hospital, we had 34 active staff physicians. 12 of those were family practice internal medicine. Today there are 15 and only 4 primary care internal medicine physicians, no internal medicine whatsoever. And it's because you can't make a living in a rural community when you've got that kind of reimbursement and that kind of administrative burden. Again, in large systems, you can have somebody dedicated to each MCO to figure out how the rules are played. But in a rural setting, how can you do that? It's impossible. I heard Senator Alvarado talk about this, that he hired 2 people in his practice just to follow this. This does not provide health care. You know, we pay too much for health care to begin with in this country. And every dollar that we spend should be spent on improving the quality of care, improving access to care, and making the system more efficient. None of this does this. Since we've been under the MCO model, we have spent $10 billion. And have we improved the quality of health care in Kentucky? I don't think we have. At that time, we were 49th in the nation. I think we're 44th now, but I don't think it's because we've improved the quality of care. We've improved some access to care. But I want to caution Ken, adding more people to the Medicaid program, that is great. It provides people coverage they've never had before, but that's not commensurate with access to care. And rural communities are collapsing under the weight of this administrative burden. It makes no sense at all. As you know, I'm co-chair of Government Contract Review Committee, and a couple of my guiding principles is operate the state like a business. Secondly, spend the money like it's your own. And why in the world would you hire 6 different groups to administer a program when the federal government only requires 2, and we've compromised with 3? Now, the excuse that I get is, well, the same thing could happen that happened back when the program started, that one of the MCOs might bolt, and that's going to create all kinds of havoc. Not if we're doing our jobs. I think it's the job of this administration to properly vet those MCOs, have a contract that bends in those safeguards, and makes this program secure. You know, we had no problem at all turning our foster program over to a single managed care source. So why is health care any different? This just adds additional administrative burden that has no purpose whatsoever. And I can march literally thousands of healthcare providers to this table today And you could ask them, does this improve healthcare? And they'll tell you, it does not. Does this increase administrative burden in healthcare? It most certainly does. It's not just an administrative nuisance, it's crushing small providers, rural healthcare providers particularly. And where do we go from here? We truly are at a crisis situation as evidenced by this COVID situation. It's not just trying to improve profits for these people, it's survival for these people. And we've taken some measures that improve their reimbursement, make more funds available to them, but that just lets them tread water. It doesn't raise them up. One of the things we can do and we should do is reduce this unnecessary administrative burden that adds nothing to quality care, or reduce cost, or make it more affordable for average Kentuckian. So this isn't just an ask. This is a plea. We have to do something. And again, I'd ask you to ask any healthcare provider, does having 6 MCOs make the Medicaid program better? If you can find a single one that will say yes, I'll drop this and I'll go back home and do what I did before I came here. But this is a serious situation. It's not just because I'm from the hospital industry. It's on behalf of our rural communities. That's what's most important. If we don't have the structure in place for our education system and our healthcare system, rural communities are not going to survive. That's why this bill is so important to me and why we need to make this restriction. Of course, I found it very interesting, this risk issue with insurers, that, they may bolt. Well, why do we have so many people lined up to want to be MCOs? I think it's really interesting that the 2 largest lobbying expenses of the executive branch are 2 of these MCOs. And why do they do that? Some protectionism there. They're concerned about this as well. I think it's truly interesting when this was challenged back in Judge Shepard's court, that one of those MCOs used my testimony as justification for why they should be considered as an MCO. There's no risk in this. They're making profits. They're very well. And if anything, it makes it a symbiotic relationship. Helps providers, also helps the remaining insurance companies that cover this. Makes it more competitive, reduces administrative costs for our state, because I don't think we understand how much it costs to audit these MCOs to make sure they're complying with the regulations. So we're doing that 6 times when we could just be doing it 3 times. So it just makes good business sense. And again, if it were your money, you would do the same thing I'm asking you to do.
Thank you, Senator. I know our practice, when the ACA rolled out, I think we had 3 physicians, 4 nurse practitioners total in our practice. We had 2 full-time staffers dedicated just to handle administrative burden from the insurance companies that we worked with. That was the difference really between us having to stay profitable and not having to sell our practice out, as many doctors and medical practices have. I think we're upwards of new docs that are coming out, 70% are employed at this point, just because trying to do it on your own is impossible. So appreciate that. I know this is a bill that we've heard before. I know we do have on the line virtually, I believe we have Commissioner Lee and Kelly Rodman. If you're there, we would like to have your input. I'd like to be able to, at least when we're presenting this, we've passed this bill through the Senate a couple of times now, I believe. I'd like to know where we stand right now in terms of our contracts. And if you could kind of enlighten us as to where we are with that right now, with our RFP processes, and the number of MCOs we currently have, and kind of what situation we're in there.
Good morning. I'm Lisa Lee. I'm the Commissioner for the Kentucky Department for Medicaid Services. Thank you for allowing me to be here with this important legislation. Senator Alvarado, I think to answer your question, we currently have 6 managed care organizations. The contracts, we are in some litigation right now. So the RFP process has not started for the next round. We are waiting on that litigation to be settled. I think it's important to note the very reason that we moved to MCOs back in 2010, that was for budget predictability. And, we do have some predictability in our budget because we pay the MCOs a per member per month payment, which helps us plan for our budget as we go forward. I think also that it's important to note that we are at the 10-year anniversary of statewide Medicaid managed care in Kentucky. As we've discussed in this committee before, the cabinet have embarked on a project with the University of Kentucky to evaluate the effectiveness of managed care in Kentucky. What we are seeing in that report is that there have been some improvements. We are mainly looking at the satisfaction of our members. We do show that members are satisfied with the services they're receiving from the managed care organizations. And as a matter of fact, this open enrollment period, when individuals had a chance to move from one managed care to another, less than 1% actually moved to a managed care from one managed care organization to another. And I think it's also important to note that Medicaid does cover a lot of services that commercial carriers either do not or will not cover. So when we look at Medicaid in the scheme of things and our healthcare delivery, we are a major payer in the healthcare delivery. And I think that we do share the vision of a healthier Kentucky, and that we need to work in moving Medicaid from more of a payer to a driver of healthcare policy, because as Senator Meredith said, we do cover 1.6 million individuals in the state of Kentucky. That's a large number of individuals, 1 out of every 3 that we cover. And it's nothing to boast about, because that means that those individuals live in poverty. And also going back to Senator Meredith's statement about Medicaid paying 75, I think he said 75 to 80% of the cost of care. We hear that, but without an all-payer claims database for us to actually analyze the payments of commercial carriers, we're not really sure where Medicaid lies in the scheme of things as far as payment goes. And I think if we really want to reform the healthcare delivery system, we are going to have to get at the true cost of healthcare. Like Senator Meredith, I do not want any of our rural hospitals closing. I don't want to burden on any of those communities, because we have a lot of safety net providers there. We have some fantastic Medicaid providers throughout the state, and we want to make sure that we take care of them, because that my mantra is the Medicaid program was created for the Medicaid member, but we cannot take care of our members if we don't take care of our providers. So I'll stop there, take a breath, and see if there are any questions.
Thanks, Commissioner. There are going to be a few questions. I'll just make, and I appreciate that last line. I think that's very important, because ultimately people talk about health care like it's a thing, and it is obviously a thing. It's a noun. But healthcare is ultimately the people that provide it. It's the knowledge of the individuals. It's your nurses, your doctors, your therapists, every orderly that works in a hospital system, any person that works in a clinic setting. That's what healthcare ultimately is. And so we talk about satisfaction of the members. There needs to be also consideration of the satisfaction of the providers, which has not been good. I've been one of those who's been very vocal, as everybody's heard in this committee many times, about the dissatisfaction, and it continues, and people are longing for the days prior to MCOs. I talked to a lot of providers who, weren't thrilled with it back then, but they said it was more predictable for them as far as their budgetary things, and it's become less predictable. We're having to drive providers into employment models that makes it more difficult. I also want to remind the members, how we got to the situation with the litigation that you're talking about. We had a reissuance of RFPs that started out. This was done when the current administration kind of took office, and there were 5 contracts that were issued. There was one individual from the governor's transition team who had inside information, was reviewing a lot of these contracts, had inside information regarding this stuff, and then was promptly hired by one of the MCOs to be part of their consultants at a very hefty monthly fee to review and help them achieve those contracts. They were one of the ones that were selected. And then there was lawsuits coming in saying it was, and I would arguably it was unethical to have that individual with inside information from all the MCOs helping to get that done. We've passed a law now to outlaw that and make that illegal, so you can't have a transition team member with inside information to be able to do that. When it went before the judge, we have our Judge Shepard here decided, hey, look, we're just going to include everybody, and made a decision, an executive branch decision, which I don't know that he can make, but made a decision to say we're going to issue contracts for everyone, which I think is beyond his purview from the judicial branch. And everyone wound up getting contracts, only to have a countersuit come, which is what you're currently involved in, to say, listen, we were offered so many lives, and it's become a big mess. And now we're in the situation where the judge has come back in and said, well, let's go ahead and just issue an entire RFP. So we have a judge currently who is making executive branch decisions, which I don't think he should be able to make, instead of ruling if something is legal or not. So that's where we find ourselves in the current situation. Not sure how long it's going to take for this, that we have currently 6 MCOs in the mix, and it's become an absolute legal mess. And I think because we have an overreach from the bench. We do have a few questions. We'll start with Senator Givens.
Mr. Chairman, thank you. And I want to start with a compliment to you, Senator Meredith, and the work you've done here. And in doing that, it's been interesting listening to your testimony and Commissioner Lee's conversation and the discussions that are going on here, because there's a bit of a history lesson in this conversation that I think can benefit us all. I think it was around September of 2011 when then Governor Steve Beshear unilaterally implemented MCOs in Kentucky. Now, I chose those words very carefully. This was a unilateral implementation by the executive branch of this Medicaid delivery model referred to as managed care organizations. The General Assembly wasn't involved. We weren't part of the process. We weren't even part of the conversation as then Governor Steve Beshear sought to do this as a delivery mechanism, largely to pull down costs. And Commissioner Lee, you spoke to that, and I think you're accurate in that if we had a graph of the potential increase in medical costs over time relative to what Kentucky's seen, there would probably be a benefit shown there. So I want to be careful in trying to be accurate. That has come at the expense of some folks, as you indicated in your testimony. Largely the provider community is the one that's absorbed that delta in the change in cost. I don't share all those things to say, hey, everybody needs to know it, but I think the history is important. I think the other history that's quite important, Senator, is something that I think I'm correct in saying, and I want you to correct me if I'm wrong in saying this. What you've done here is not a partisan effort at all in any way, means, or fashion. If I'm correct, you filed this when we had a Republican governor.
I did, yes.
And you had family members that were part of that administration. So it was not like it was something that you were not passionate about, because you've been passionate about this when we've had Republican governors and now Democratic governors. So this is not something you thought of just the other day.
No, sir. And, you know, I adopted a philosophy very early on in my career as a hospital administrator to always pursue symbiotic relationships. In other words, win-win for everyone. Because I found out that's the only thing that works long term. And I don't want to leave the impression that I have qualms with the Medicaid program. It's a vital part of Kentucky, providing critical services to people throughout this state. So my criticism is not in the Medicaid program. We need it. My criticism is in the administration of it. And I have nothing but respect for Commissioner Lee. She's worked with us hand in hand, and I've enjoyed that relationship. But she may note that this program gives the state financial security, also gives the MCOs financial security, because they're guaranteed that they're going to get at least 10% of the Medicaid dollars. But it doesn't give financial security to the providers. Now, if you're in an urban area, you can offset that by a great degree because you have commercial pay insurance that will cover it. Even in my small hospital, a 1% increase in what we call our payer mix, percentage of patients who have commercial pay insurance, a 1% increase would improve our bottom line by $100,000. But we don't have that opportunity that you have in urban areas to increase that commercial pay base. So my issue is, it's not the MCOs. As a matter of fact, we heard testimony this summer from some folks in Colorado how they had changed their MCO program, and I think it can work if the appropriate safeguards are in place. I still think there's a different model, better model that Senator Alvarado and several of us have talked about, but I'm going to work with the MCO model to make it even stronger. But I'm just saying that what present structure with 6 MCOs places a disproportionate financial burden upon rural providers that's not fair. You know, we've talked a great deal about everybody being treated equal, and that's something that the MCOs will tell me constantly, that they're treating everybody the same. But we know that being treated equal is not the same as being treated equitably. And that's what's happened in rural communities. This is a disproportionate burden on rural healthcare providers that is causing them to collapse, and this is no exaggeration. I'm not prone to exaggeration. So again, I think this can work. It's just 6 are too many, and just trying to keep up with the rules are virtually impossible for rural healthcare providers.
So Commissioner Lee, Senator Meredith spoke to the question and made the statement regarding disproportionate financial impact and the weight of that Chairman Alvarado used the phrase, and accurately so, in response to your presentation regarding satisfaction of the members. Chair Alvarado raised the phrase satisfaction of providers. And so when we think about this system and we consider the health of the system as a whole, if we're thinking about the health of the system as a whole, and the bill sponsor's main concern is this overburdensome multiple credentialing requirements by different MCOs, pre-authorizations that take all sorts of different combinations of efforts to try to get forms that are not aligned and streamlined and similar in the filing process. Each MCO having an individual process to get to the same place. In light of those concerns that he's raised multiple times in multiple sessions, and the Cabinet's opportunity as the contracting entity in negotiations with these MCOs, is there anything that precludes the Cabinet from writing into the RFP a flat statement of each MCO shall comply with this form, this process, this pre-authorization, and this credentialing mechanism? Can the Cabinet do that or not do that?
The Cabinet does have in the current contracts information and rules related to prior authorizations. For example, all MCOs have to use an accredited prior authorization process such as Milliman or Interqual. So we do have some of those provisions in the contracts. However, we do not specify specific procedures that must be prior authorized. We have streamlined some of those processes by trying to come up with a form for prior authorization processes, but as you can imagine how difficult that is when you're looking at durable medical equipment versus physician services. There's one form is not going to fit all, but we can streamline those processes as much as we can. And as a matter of fact, right now, we don't have any prior authorization on behavioral health services or the medications to treat behavioral health services. We have lifted some of the prior authorizations specifically during COVID. And I think that this provides us an opportunity to look at the prior authorization process and make it streamline it and make sure that we have processes in place that are actually resulting in quality care for our providers and for our members, and that they're receiving the services that they need to receive without barriers to care.
Thank you for that response. One quick follow-up, Mr. Chairman, if I could, and I would encourage in a very positive way the Cabinet and Commissioner Lee in the role you play to be wise in acknowledging the fact that we're the customer. The state of Kentucky is the customer. These MCOs are the competitors to access us as the customer. And I've long felt, and certainly don't have the inside information and knowledge that you and your colleagues do, but I've long felt that through that contracting mechanism, we have every authority to say, this is what we're buying, this is what we're paying for, and if you can't provide it via this structure, then you shouldn't respond to the RFP. I think that's largely an underlying, and I don't want to put words in the senator's mouth, but I think that's largely the underlying concern. I don't know that the senator would care if it was 3, 5, 18, 21, as long as the provider interface was so much more streamlined and the process so much less burdensome. Thank you, Mr. Chairman.
Thank you, Senator. Senator Berg.
Thank you, Chairman, and thank you, Senator, for bringing this issue. I do have a statement and then a question. First of all, my statement is I know that you see this from a rural healthcare perspective, and I see this from an urban healthcare perspective, and I would like to remind everybody in this room that even though I understand thoroughly that our rural healthcare providers and systems are in danger and struggling, I just want to remind you that our urban healthcare systems are as well at this point. I personally was trying to get an appointment for a family member, semi-emergent, at U of L, outpatient setting, 1,200 patients behind. 1,200. 1,200 patients in front of this child. So I just want to let you all know everybody is struggling. And then I have a question. I understand we have 6 MCOs. Each one of them have different rules for prior authorization, different rules for what they'll cover, what they won't cover. It is extraordinarily confusing for healthcare providers. I heard a number once that the average physician office in the United States spends an annual $100,000 on billing, trying to get insurance companies to pay the providers for their services. I think that is an absolute tremendous waste of healthcare dollars, and it sickens me every time I think about the amount of money that we're spending not delivering medical services. So my question is, if we can streamline this for the MCOs, what stops us from streamlining this for United and Anthem and Blue Cross Blue Shield and Aetna and every other one of the providers that each of us individually have to go through and meet their requirements for a service? Can we not somehow standardize this so that to take the burden not just off of the Medicaid, which I understand is a third of the population, but to take the burden off of the private, the people who have to bill private payers as well, which is actually much harder, much more time consuming, and intentionally designed not to reimburse. So I'm just asking as a novice, basically, why are we not addressing this on the larger picture?
Well, is it directed to the senator? or is it just a global? That's a question for another. Yeah, it's a global question for other bills perhaps to consider, and that's something you could probably tackle if something you're passionate about. I know the Senator Meredith has addressed this with Medicaid. This is a bill that we've addressed multiple times when it comes to Medicaid directly in that regard. Senator Meredith, you want to address that?
We all know I use a quote from Mahatma Gandhi that the world is large enough to take care of everyone's needs, but it's too small to handle everyone's greed. And unfortunately, we have too many people making exorbitant profits on the misfortune of others, and that's what they do. You may remember several years ago the attempt to have a universal bill. Couldn't be more simple than that. Could not accomplish it because, again, the idea is not to make this system easy. I think it's actually a misnomer. It's not managed care organizations, it's managed cash organization. And I heard reference earlier about the not doing pre-admission for mental health. And I understand now that the MCOs are going back and auditing mental health providers and taking those funds away from them because they know that to appeal those is virtually impossible. It's a game that they play. So there's a component of greed that's in this, and it's throughout the healthcare delivery system that we're going to have to address at some point in time, and I'm not sure how to do that. But for this particular program, I think we have this opportunity. Even one of the things that we've attempted to pass, such as single source credentialing. Again, how could it be any simpler than just one source for credentialing? But we haven't been able to accomplish that yet. And when I talk to the MCOs about that, and they say, well, there's the system that you put together doesn't meet our needs. Well, it's not about your needs. It's about the needs of our constituents and our providers. And sometimes we forget that the healthcare providers are indeed our constituents. And again, I ask you to bring one person to this table that's a healthcare provider to say this is a workable situation for them, and they'll tell you no, it is not. Now, to the issue again about the financial security for the state, I think this bill doesn't touch that. You can still have that financial security and stability with 3 MCOs versus 6. So provider satisfaction and constituent satisfaction, I think it's still there. But the cost that we're putting in this program is not sustainable. It's going to collapse the healthcare system in rural Kentucky. And then what do? We got a whole new set of problems to deal with. And there's enough money to take care of everybody fairly if we do it from the standpoint of a symbiotic relationship, but it does not exist, and it should, and that's what I'm pushing for. If we have 3 and we can make it a workable MCO system, which I think it can be, then we all benefit from that. But right now, it's not a system that can sustain itself in rural Kentucky.
Very good. Senator, let's do our last question, Senator Carroll. Very good. We have a motion. Is there a second? You have a second? Any other discussion? If not, Madam Clerk, please call the roll.
Senator Rocky Adams. Senator Berg.
Aye.
Senator Carroll.
I'd like to vote aye and explain my vote.
Please proceed.
I appreciate you bringing this bill forward again, and I'm going to do all I can to get it passed. coming from the perspective of a small provider, the most frustrating issue that we deal with is our MCOs, and we are a very, very limited in scope provider with very limited codes that we use, yet every year with at least one MCO, we go through the same ordeal. The system is used against the providers, as was stated, and for a small provider, $70,000, $100,000 recoupment, that adds up pretty quickly, and then you find yourself having to spend additional time fighting to keep that money or get it back. And the system is inefficient, and I have no problems with supporting the MCO model, but it can't be efficient for the state to manage either the way it is, and we're not controlling it well enough through contracts with them. We've talked about this for years. We've talked about legislation to set certain standards. That hasn't happened. We've got to do something, and I think narrowing it down to performance-based model. The three best MCOs, that's who we keep, and then some of these issues may go away on their own based on that. But we have got to get this bill passed, and we've got to provide some relief to the burden that providers are encountering, not just in workforce issues, but also in financial issues, because the system it's designed to take money back away from the providers, and that's just unacceptable. Thank you, Mr. Chairman.
Senator Givens. Senator Harper Angel. Senator Howe.
Aye.
Senator Kerr. Senator Meredith.
I'd like to explain my vote, Mr. Chair.
Please proceed.
I vote aye, of course. But last session, we passed a bill, the TIF bill for the west end of Louisville. And during that discussion debate, I asked, what are we doing for our rural communities where poverty is still crushing many of our counties? And I received a commitment then from several senators that whatever we can do to help rural Kentucky, we'll do. And I'm telling you, this is not a small bill, a small task. This will go a long way towards stabilizing the healthcare system in rural Kentucky, which is also a major economic player in rural Kentucky. So again, that's why this is so important. But thank you, Mr. Chair.
Senator Nemes.
Aye.
Senator Wise.
Aye.
Chairman Alvarado.
Aye. The matter passes favorably with a vote of 9 yeses, 0 noes, and 0 passes, and will be reported favorably to the Senate floor. Thank you very much, Senator. We appreciate your work on all these bills.
Thank you, Mr.
And
Chair.
Commissioner, thank you for joining us. You're welcome to stay on. We appreciate your testimony and answering some of our questions as well. The last item on our agenda is Senate Bill 100, which is an act relating to essential caregivers and declaring an emergency. The sponsor is Senator Julie Rocky Adams. Senator Adams, if you'd like to make your way forward and introduce yourself and begin your testimony whenever you're ready.
Thanks, Mr. Chairman. I hated to interrupt the Senator Meredith show, but I'm very pleased that you have allowed this bill to be heard at today's committee meeting. I'm Julie Rocky Adams, State Senator from District 36. Senate Bill 100 is the Essential Caregivers Bill. The purpose of this bill is to establish an essential caregiver status for family members, guardians, friends, and other individuals who would be allowed to visit residents in long-term care facilities, assisted living communities, and state-run mental health hospitals under certain safety protocols established by the Cabinet for Health and Family Services. So this legislation is really closely modeled after the essential caregiver provisions that were included in the 2021 regular session House Bill 1 and the 2021 special session Senate Bill 2. Really, the only difference in this language versus that is that we added in mental health hospitals that are state-run. So that's the only adjustment to this language. The essential caregiver provision included in Senate Bill 2 is set to expire on January 31st of this year, which is why this legislation has an emergency clause on it. So if you look, Section 1 does create a new section of KRS 216 to include requiring an assisted living community, long-term care facility, and state-owned operated mental health hospital to permit an essential caregiver to visit a residence within the facility. And then Section 2 is the emergency clause. And I'm happy to take any questions that the committee may have.
I'm going to read an email, Senator, that I got this morning that I think is poignant for this bill. It's in support of this bill. And I'm not going to disclose a person's information. I'm not sure how much they want, although I think they might be watching this today. And this is what she says. My father has been an inpatient at Eastern State Hospital 5 months due to a dementia-related event that resulted in an altercation with his neighbor. He has delusional dementia and paranoia. Patients who have been admitted to state-run hospitals are denied access to nursing homes, which is the level of care that he needs. My issues are twofold. Number one, he's being denied visitation, as are all patients at state-run mental health hospitals in Kentucky. As the saying goes, mental health care is health care, and these patients obviously deserve the same rights as any patient. I understand the impetus to keep them healthy due to the communal nature, and yet we truly kill mental health patients by denying the option of visitation. I contacted every surrounding state, the conservative and the progressive, and they've allowed visitation in their state-run hospitals since March of last year. If the issue is not escalated, my fear is patients like my father may die having never seen their families again. And number two, I would also like legislation issued requiring that Medicaid and Medicare accepting nursing homes in Kentucky cannot outright deny mental health patients access. The stigma still attached and the stories told about these patients has to cease and won't cease in absence of legislation. They are simply not even considered. Patients like my father are stabilized and are not violent or unmanageable. They do not deserve being left utilizing costly resources when more appropriate means are available. And I think that's very poignant. And I got that this morning, and I thought I would read it here today about the importance of this. I thank you for bringing this forward. It's something during the pandemic that able to provide a temporary solution, but we need a permanent solution. So I appreciate you bringing it forward. We have a motion on the bill. Is there a second? We have a second. Any other discussion or comments? If not, Madam Secretary, please call the roll.
Senator Rocky Adams.
Aye.
Senator Byrd.
Aye.
Senator Carroll. Senator Givens. Senator Harper Angel. Senator Howe.
Aye.
Senator Kerr. Senator Meredith. Senator Nemes.
Aye.
Senator Wise. Chairman Alvarado.
Aye. The matter passes also unanimously with a vote of 9 yeses, no noes, and no passes. It will be reported favorably to the floor of the Senate. Thank you and congratulations, Senator. Any other questions or discussion before the committee? If not, we stand adjourned. Thank you.